insurance is not healthcare. Insurance, and I said, look, here's my ID card, and I pull out my military ID card, which of course is the same as basically my insurance card. I said, just because I have this card doesn't necessarily mean I have access to care, and I can't rub this card anywhere on my body and make myself feel better. It actually requires the intervention of a healthcare provider, a healthcare team, a healthcare institution to turn this insurance card into something that's meaningful from a healthcare perspective.
"15 years ago, the Affordable Care Act promised a major transformation of American medicine. Lower premiums, expanded access, a system that worked for both patients and physicians. Some of those changes did happen. Millions gained coverage and insurance markets expanded. But as we learned in our previous episode with Dutch Rojas, the deeper structural problems in healthcare didn't disappear. Insurance companies, hospitals, and big pharma had a hand in writing the ACA and have benefited from its implementation. Costs kept rising. Hospitals faced new financial pressures, and today policy changes are once again threatening the collapse of healthcare for millions of Americans. The two players that have suffered the most under this Obamacare, as we've come to know it, are doctors and patients, and the relationship that defines healthcare for most of us. What actually changed after the ACA? And where does the system go from here? Today, we're joined by someone who studies healthcare policy from a uniquely operational perspective, looking not just at healthcare and legislation, but at what happens inside the hospital and health systems once these policies hit the real world. Welcome back to Vital Discourse. Today, we're joined by Dr. Brad Beauvais. Brad is a healthcare policy researcher whose work focuses on hospital finances, quality outcomes, and value-based care. He previously served for more than 2 decades in the U.S. Army Medical Services Corps, where he held leadership roles across several military healthcare systems. After leaving the armed forces, he briefly joined the faculty at Trinity University, where I met him, and is now tenured faculty at Texas State University. His research examines a critical but often overlooked question: how the financial health of hospitals affects the safety and quality of patient care. Brad, glad to have you here.
Thanks for having me. It's good to be here.
Talk to us a little bit about what you see as the big picture of how the ACA has been implemented and where we stand today.
Oh goodness, that's a big onion to unpack or unpeel. So I think I'll take the perspective of looking at where we are 15 years hence after the passage of the ACA, and certainly I have to say with all honesty, I think the ACA, as it was originally conceived. Was altruistic, right? There's a lot about it that I think was beneficial. With respect to, for example, when I was doing my doctoral studies at Penn State, I had several of the senior faculty that were working on mental health parity and ensuring and trying to get some degree of insurance coverage for those individuals that had behavioral health needs. And the ACA helped to solve that, or at least put it, front and center as part of one of the essential health benefits. I think there's also the notion of, pre-existing conditions in general. I mean, it sounds good. It feels good to be able to tell somebody that is in serious medical need that you now have access to the insurance markets, where before they were frozen out. And I think, the act, helped to refocus our attention, perhaps not completely, on, of course, expansion of the insurance offering to those that weren't able to get it for socioeconomic reasons, as well as those that, might not otherwise seek care. I think there's some benefit to focusing our attention on quality, right? Ensuring that we continue to focus, or at least strive for, improved quality across the system. Now that we're 15 years beyond it, we've seen some of the benefits as well as some of the ramifications of the act we have had an expansion of Medicaid. I forget how many states now have voted to expand it. Of course, through 6 or 7 rounds of Supreme Court legislation, it is now the law of the land, whether we like it or not. And the Supreme Court has basically said enough. If you want to fix it, Congress, you need to fix it. You need to come up with some other congressional act in order to replace it. And we've seen a lowering of our uninsured population, which is by itself a good metric to be able to look at and point at and say this is something that the ACA did. But we have to recognize that there are some pretty significant and serious flaws that were either partially or wholly caused by the ACA. In terms of affordable, if it's the Affordable Care Act, we've witnessed health insurance premiums continue to skyrocket to a point where they are untenable to some, and as they continue to move in that direction, are going to be untenable to more, if not many. They really have only been propped up, and this is probably something we'll talk about later, with the premium support. They really have only been tenable after the last couple of rounds through the various legislative acts through the Biden administration. The premium subsidies have really kind of masked the true cost of health insurance. And though now that those are coming to an end and coming center stage again at the congressional level, it's something that we're going to have to contend with at the congressional level and as well as throughout the industry. Beyond that, Lee and I were talking a little bit before we started recording. Even though it's nice to be able to say that Medicaid expanded and that more have access to health insurance, we have to recognize that the reimbursement rate that facilities get via Medicaid is far below operational cost. So those that were formerly uninsured are now able to gain access to health care, which is good. But as they do so, the economic theory of adverse selection kind of rears its ugly head in the sense that they will now seek care more often. And of course, they're insured. So those patients that were formerly no-pay or low-pay patients, or those folks that would only seek care only if they absolutely had to, now are seeking care more often, but the reimbursement rate for those patients is far below where we are from an operational perspective.
I mean, to your point, Brad, I mean, that's a great point. And I just as a clinician, and Lee can chime in also, I don't know many docs that accept Medicaid. And if I did accept Medicaid and I needed to do surgery on somebody, I don't know where I'd take them that accepted them to do the surgery. Because again, to your point, Brad, it's so far below what it costs to actually do the surgery that it can't get done. So coverage doesn't really mean that you're covered. I mean, it's great if you say you're covered, but what does it really mean to be covered? On the Medicaid side or the Medicare side, there's so many things that aren't really covered, and certainly in the private insurance, you don't really. The private insurance companies seem to be able to just sort of pick and choose and say, "Yeah, I'm not going to cover this, and I won't cover that." And so, what does it really mean to be covered? I mean, if there's things that the doctor and the patient decide that they need to do, and then they try to do it, but the insurance company won't cover it, you start to feel like maybe you're not covered, even though it says that you're covered. How is that being handled on the hospital level?
Well, and just an anecdote. So in my days at Penn State, I had there were fairly contentious discussions with a couple of health economists. I'll leave their names out of the discussion, just for the sake of, protecting the innocent.
Parsimony.
Yeah, just to be kind. I, of course, spent 20 years in the service, and we were always covered, of course, through Tricare, and we were active duty, but in many cases, the reimbursement under Tricare is not too dissimilar from the reimbursement under Medicaid, right?
Right. Well, not many places take Tricare right now either. I keep seeing Tricare because I was I was obviously a 20-year veteran myself, and so I take it. But I have a hard time, if they need to go to surgery, I have a hard time finding a place that will accept Tricare.
So to that point, we're having these discussions in the healthcare economics class, and I think I mentioned this actually in a couple nights ago when we were talking on the phone. In one of our discussions, on campus, I told my professor, like, look, insurance is not healthcare. Insurance, and I said, look, here's my ID card, and I pull out my military ID card, which of course is the same. It's basically my insurance card. I said, just because I have this card doesn't necessarily mean I have access to care, and I can't rub this card anywhere on my body and make myself feel better. It actually requires the intervention of a healthcare provider, a healthcare team, a healthcare institution to turn this insurance card into something that's meaningful from a healthcare perspective.
So it's a great point that you're making, Brad. And with that in mind, I kind of want to ask you something that's going to be the theme for me anyway in this discussion. So it has been postulated that the ACA, or Obamacare as we know it, was kind of always designed to fail in order to usher in single-payer healthcare. Is this part of this? I mean, in other words, you're telling me that some of the best economic minds got together to produce this, and they couldn't see that publicly traded companies kind of in charge of medicine, I'm talking about the insurers and hospitals, are not going to continually increase the amount of money that they want every year to the point where we are now, where it's untenable and premiums and deductibles are high. So what is your take on that general 40,000-foot view?
Well, this is documented, and we can look this up. One of the original architects of the ACA was Dr. Jonathan Gruber. And I think we've seen on video where he basically openly admitted that there was some deliberate obscurity of at least the CBO scoring.
Yeah, the lack of transparency. He demanded that they have lack of transparency to pass the bill. And when I don't even know how to address that other than it was really never tenable from the start, in my humble opinion. And one, by his open admission on camera, on video, which we can locate on Google, pretty readily. But I also think it's the ACA. I think it really set aside, fundamental human behavior. We all act in our own economic self-interest. This is Adam Smith, 101. When it comes down to the choice between keeping a roof over my head, keeping food on my table, and having health insurance, I can tell you which 2 out of the 3 I'm going to pick, right? And now that we're getting to a point where it is increasingly untenable, I think we're going to get to a point where we're going to see individuals that are simply going to drop health insurance, except for those that are the absolute greatest need, and of course that becomes its own doom loop, if you will, as those that have lesser need for health insurance jump out of the market and take themselves out of the risk pool. That leaves only those that are in the risk pool that need it. And of course, those are the higher acuity, higher need patients, which then, of course, is going to continually drive up the cost of the premiums. So that kind of, I think, partially addresses the question. I don't know that I have the full answer. One of the things that Lee and I were talking before we started recording, there's also the concern of, even though Medicaid was expanded, and we've previously just talked about the cost, and the failure to be able to cover operational costs. Well, as Medicare continues to take over an increasing share of our payer mix, coupled with Medicaid, and its failure to fully reimburse facilities and individuals for the care that's provided, that puts more pressure on the commercial market, which then, is, if you understand
the payer mix and you understand how hospitals negotiate for their the pricing of their care, well, that means their charge master just gets pushed up in terms of their gross charges. Then of course becomes the new negotiation point for anything where any commercial insurer is going to negotiate for reimbursement. And so that in itself becomes its own doom loop, right? Because as Medicare expands with the graying of the population, that means that less and less, or there are fewer and fewer commercial patients, commercial beneficiaries in the labor market. And then, of course, that means that those premiums have to keep going up in order to offset the losses that are incurred in the Medicare and Medicaid population.
So that doom loop you're referring to sounds a lot like what I was suggesting. I mean, a lot of people accuse the framers of this bill of knowing that while it is going to expand healthcare throughout the U.S., that it's kind of doomed. It's going to set up a scenario where so many people are disgruntled with it, and then you pop up at some point, 15 or 16 years into it, supposedly, and say, well, the things are so broken, let's try single payer. That's what that doom loop you're talking about sounds like to me. Is that fair to say?
I think we have to be careful what we wish for, right, with respect to single payer too, right?
Yeah.
Simply because we see other examples of it around the globe, Canada and the NHS system, and while there's many that look at them and with joy and glee and say, look at this great system we have. As we've discussed last night, we have our own versions of single payer here in the United States in the form of the VA, the Indian health system, to a lesser extent the military healthcare system. And each one of those struggles mightily with cost, quality, and access, like kind of the iron triangle of healthcare delivery. Such that, fortunately for the rest of the globe, there is an outlet where some of the patients that have means can come and have some of their needs addressed. And the outlet, of course, is the United States. If you travel.
Well, it's also, but there are examples like Australia and New Zealand that have a two-tiered system where you have Southern Cross, which is a private payer down in New Zealand and Australia. And if you have the means, they have their own hospitals, clinics, and providers, and you can pay for it, and you immediately have better access. You're not put in queues and waiting, and you have access to care that can be done more immediately. Whereas the rest of it, the public system does have a bit of a capitation, and you are in queue, and there's only so much money to go around. I don't think there's anything wrong with that system. I think I've worked down there in New Zealand. I was licensed to practice down there, and it works. I think it works pretty well. That all systems have their bad part, but I don't know why we have not wanted to go to that sort of clear two-tiered system. It seems to me that you should have a base care for everybody, and that because it's a base care and it's being paid for by public dollars, that there's a little bit of a weight, and that you have to accept a little bit of capitation, right? But if you do have the means for it, that you're able to go to a private setting and tailor your care a little bit. Do you see that as a viable system in the U.S.?
I do, and we kind of see that evolving even in the UK, right? There's a private insurance market, that augments or supplements the NHS, and it kind of, it aligns with the paper that we put out, if only on LinkedIn, back in 2016, right, where we looked at Medicare Advantage for all. There's a certain amount of logic to me that and that I believe makes sense, where we all have essentially a baseline level of primary care. We all have an idea that we do have some coverage, and we can start to look at things through the prevention and wellness lens versus the simple kind of reactionary, and we only get involved when there's something acute going on. And of course, that's it sounds good, and I think it's probably makes sense from an economic and long-term sustainability perspective. I question whether we can get the pipes and plumbing right from not only a legislative but also basically a functional or organizational perspective as well. Because it would require a pretty robust reworking of the pipes and plumbing of our healthcare institutions.
Unpack that a little bit, right, for the viewers, because what do you mean by the plumbing? What specifically would have to change in order to get something like that going?
Well, I mean, just off the cuff, I think we would need to move into more of a systems level thinking. I mean, if we look at not that I really want to use it as a model, but if you look at the Veterans Administration as a kind of a blueprint, you have to have, a pretty robust set of primary care providers that are within a reasonable, traveling distance to the beneficiaries that they support. And then the question becomes, well, of course, how many more providers would we need? How do we ensure that we have, the geographic dispersion that makes sense? That's, again, sustainable.
Do you think that those providers, this is an overall question going to the hospital perspective, which is really where your forte is. There's been a lot of consolidation, and I think it's extremely detrimental actually to the overall system, but that consolidation has included buying up private practices. Do you think that care, including primary care, is better delivered by an all-encompassing hospital system or by grassroots private docs out in the community, giving care to the people that they live and work with?
I see two sides to it. I think if the system is robust enough that it can have enough reach to, and basically allow for, meaningful and economically viable vertical integration, I think it makes sense. I will tell you, it's nice, to be able to be on one electronic health record. So all of your information, data, medications are all captured and known by that healthcare system. I think there's some positive quality outcomes that we can trace pretty directly to that knowledge, medication errors alone, let alone, some others. But I think the question is, and again, do we allow a systems perspective that, it's kind of nice to be able to go to your hometown provider that you've known your entire life, that's been around your family. There's a certain amount of just background knowledge and understanding, if nothing more culturally, as well as, general, acceptance within the community. I think that's meaningful as well. So, I see there, I think if we're going to talk business, and whether or not that, I think from a business and a sustainability perspective, I think the building out of the practices or acquisition of the practices probably makes sense. But again, I guess to your point, at what cost?
Well, I guess it's also just a question of efficiency. What I see, and what I think that you may agree with, I don't feel that the way that hospitals are using the massive facility fees that they're getting now in a justifiable way. So instead of building out more and better paid physicians, you get piano players in the lobby, lots of marble and brass, and really nice eating facilities. That's what I see in hospitals, and I think that's what the patients see also. They see really pretty places with massive numbers of administrators running around, and then a few underpaid docs overworked with 7-minute visits. So I don't see the hospital system, as it currently stands anyway, as a very efficient way to use money. So I mean, I think that it has its place, I think that for care that we talked about before. So what is the, tell me what you think the best use of a hospital is with that in mind. I mean, like, because I'm not a big fan of hospitals running everything because I think they do it inefficiently. But I mean, you can change my mind on that. How do you see hospitals fitting into this system globally?
Well, I think I've known you long enough where I'm pretty sure I can't change your mind. But I think the hospitals will always have a place, right? And
Yes,
Lee and
I agree with that 100%.
actually talking about it. I think there's hospitals, we will always need trauma centers, right? We always need a place where there's a motor vehicle or some other, accident where somebody needs to go for very acute care and on an emergent basis. I think, high risk pregnancies, neurosurgery, open heart surgery, the very high end, high acuity, needs, I think are probably best served in a hospital setting simply because it takes a lot of equipment and, highly specialized personnel. And that's the best way to concentrate them and provide that care. But I think there's increasingly a cliff at which, and I perceive it to be an eroding cliff where those highly specialized services, what was highly specialized 25 years ago, is no longer highly specialized. I look at my mom who's had 2 knees replaced and 1 hip, right? That used to be an in-hospital and several day stay. Now she goes and went to an ambulatory surgery center, Black Hill Surgery Center, one of the best in the country. Phenomenal care, phenomenal pain management, has her up and moving, if not the same day, the next day. I mean, incredible care. Inconceivable, 20, 25 years ago. Now happens every day, right? So what else will erode and what else will move to the outpatient setting? I hate to even hazard a guess because as technology evolves, what was formerly inconceivable is now conceivable.
I want to push you on that for just a second. So with those things are being pushed out into less acute settings of care, right? And we can't necessarily tell where it's going to go 5, 3, even 2 years from now with the advancements that are being made. But in general, hospitals should be for the most complex care, is what I'm hearing you say. Yeah, the most acute and most complex care of the age, whatever that is. Is that fair?
Yeah, I think that's fair.
Okay.
Here's where I see kind of a problem with all this, okay? And let's talk about reality because we've been, up till this point, we've been talking very, very abstract, okay? So the reality of the situation is, to your point, a complex procedure that once only could be done in a hospital now is being done in a surgery center, right? So the reimbursement has decreased commensurate with the fact that it's in the surgery center. And the more it's done in the surgery center and the more of these procedures that are done, the less the reimbursement is because, look, the insurance companies aren't stupid, right? You now know this is the place I do it. I do it in the surgery center. I don't want to bring it back to the hospital. And many times you can't bring it back to the hospital because those mechanisms and what's needed in order to do that procedure no longer exist in the hospital. So it gets to a point where now the surgery center can't afford to do that procedure because the reimbursement has gone down so much. And the doctor can't do it because it's gone down so much. So it's being done less and less. And what ends up happening, at a certain point, it gets kicked back to the hospital because we won't do it in the surgery center. We won't do it in our office.
That's happening right now with FESs. I mean, it's very similar. The reimbursement's going down massively. And so the surgery centers are kicking it out because they literally can't afford the thing that the amount of money they're getting paid. Yeah.
Right. So now it's getting kicked back to the hospitals, and the care costs are going back up. Right. So there's this cycle that we see as physicians in private practice that keeps occurring over and over and over again. And the other thing, and that I'll get off my soapbox on that one, but the other thing that we see, and I think patients see also, is the Affordable Care Act. It promised, and to Ben's point, the hospitals were involved in the discussions and in the planning of the Affordable Care Act. The hospitals were supposed to get increased reimbursement because of less care to those who did not have any insurance. Okay? So that would increase the Medicare rolls. Obviously, you've already made the point that the Medicaid rolls. You've made the point that Medicaid doesn't necessarily pay enough to cover the costs of keeping the lights on, but they are making more than they did before. And what we're seeing is decreased care at hospitals. Why are we seeing decreased care at hospitals? Well, we're seeing once when the ratio of nurses to patients was 1-to-1, now it's 1 nurse to 10 patients. And where is it being backfilled? It's being backfilled by paramedical personnel, nurse associates, associate nurses, assistant nurses, whatever it might be. We're seeing it in the operating room. It started off with anesthesiologists. Now the anesthesiologists are too expensive for the hospital to pay for, so it went to nurse anesthetists. Well, now the nurse anesthetists are too expensive as well. So where did it go now? Now it's going to nursing assistants. And I'm not saying that a nursing assistant can't give excellent care, but frankly, it's not the same as an anesthesiologist. We see it, the patient sees it. So we see, from our perspective, the hospital margins increasing to a certain extent. We don't see where the price pressures are affecting the hospital. And that's where I would like you to chime in and let us know where are these price pressures occurring. Why didn't the Affordable Care Act cover that?
By price pressures, can you unpack that for me just a little bit?
Well, I'll give you an example. The cost of employing a nurse pre-COVID versus the cost of employing a nurse now is astronomically different.
So, right, you're talking from a cost perspective, like an operational
right.
perspective? Okay.
Right. So, we're looking at margins, right? From a purely business perspective, what are our margins? Are we increasing our margins? Or are we decreasing our margins? Our margins are decreasing, but our revenue is going up because we are now consolidating, as Ben said, meaning there are less hospital systems,
fewer hospital systems,
fewer hospital systems, and therefore the power is consolidated in terms of negotiating.
That drives facility fees up dramatically.
Right, negotiating with the payers. So we know they're getting more money each year. We're getting less. Okay, Medicare has already told us you're going to get 2-3% less every single year. Okay, but the hospitals aren't seeing that. So their revenues are going up. What's going up that's squeezing their margins such that their care is not going up with it?
So the biggest one, and you touched on it, is labor. So I'm actually, over the last week or so, I've been working on this for a longer period of time, but we just published a pretty significant paper, significant to me. Took 2.5 years, finally got it published in Healthcare Management Science with Larry Fulton, Ben, who you know. But so I had this data set, and after at the ACA, or at the American College of Healthcare Executives conference, just one of the sessions, started working on this paper and running data on that same data set, which is about 15 years looking at hospitals, short-term acute care hospitals, so the community hospitals that we all know and love. And getting ready to actually push it out for publication. And one thing, this is over, ends up being about 23,200 hospital year observations across the data set. The biggest, most significant factor that we're seeing is labor cost intensity. And this is actually, I'm reading from my paper here. A 10% point increase in labor compensation ratio was associated with about a 9.2% decrease in operating margin. Couple that with some of what we just talked about with respect to Medicaid. Hospitals with a higher Medicaid revenue share exhibited lower operating margins. So a 10% point increase in Medicaid revenue was associated with approximately a 2 percentage point decrease in operating margins. And so this is significant in the sense that most, like the kind of median operating margin, actually from this study, our operating margin, the mean is a negative 1.5%. The median is right at about 0.
So you're saying, wait a minute. You're saying that as their reimbursement from Medicare goes up, their margin goes down?
Well, Medicaid share. So as their payer mix, as they increase, so as Medicaid rolls expand,
Right. Their margin's dropping?
it helps from a perspective of there is the transition from the no pay to some pay patient, but that is not sustainable, right? In the sense that, again, we go back to the adverse selection. Now suddenly I'm insured. Now I'm coming back for more care. Well, if you're only getting compensated at a percentage of operational costs, you're not going to make that up in volume.
Yeah, but they're also paying top dollar for all their personnel. I mean, I can't compete with hiring MAs, PAs, nurses, nursing assistants with a hospital because they're willing to pay nearly double what I'm able to pay, and they're doing it. So, I mean, but that's not what nurses cost. That's not what PAs cost. I mean, you can get all those personnel for cheaper. Again, it just seems to be incredibly poorly thought out from a business perspective. And the hospitals are driving this, not private docs.
Yeah. No, I 100% agree. I think there's.
So I come back to the idea of driving this towards an eventual cliff, right? And to me, consolidation having driven up facility fees and all other costs, because they're so flush with cash and bloated with cash, they haven't done very good things with it. That's my point, is that the more cash that the hospitals seem to get, the less good judgment they use in how they're going to use that cash. And to me, I think that there needs to be site-neutral payments again. I think that you shouldn't get more money for the exact same thing just because you're a hospital. You can have higher pay for complexity, but you shouldn't have. It should be the same money that you get. If I do a CT scan at my place, I should get the same that they get at the hospital. But again, they're doing more complex care. If they want to do a fibular free flap there, I can't do it at my place. They should get more money for that, for sure. But I think it should be site-neutral payments, and I think it might start to level the playing field.
Well, and I also think we need to recognize and Lee and I were discussing this a little bit before we recorded. There's really a dichotomy with respect to hospitals. If you've seen one hospital, you've seen one hospital.
Right.
Very, very much. There is the rich and getting richer hospitals, and those tend to be those that have a higher percentage of commercial payer in their payer mix, right? Those that are on the other end of that spectrum, of course, with any, and like when I'm talking about the mean and median distribution on operating margin, the max operating margin in our sample at least was 39.1%. Right. So if I have that much operating margin, certainly I can pay more, or I can afford to pay more for my labor pool. The other end of that spectrum, my minimum, I mean, I'm losing money, hand over fist. And so what I think we're going to end up see happen, unless there is pretty significant policy intervention, I think we're going to tend to see an increase in the number of bankruptcies that happen at the low end of the hospital spectrum, because like they can't compete with the rich and getting richer hospitals. They're having to, cut corners and trim, to the maximum extent possible just to keep the lights on, and the doors open.
Well, wait a minute now. What does that mean? Because are they making the right cuts, though? Are they decreasing and skinnying down the people that don't do anything for the hospital care, like administrators? Or do they, if I go up to Conroe Hospital right now, which is a rural hospital, am I going to still see a 7-to-1, massive buildings that contain no physicians, just administrators?
Yeah, well, and, I can't, on the eaches and everys, I'm not sure that I can promise you what you're going to see next, right? But from a pure administrative, if I'm going to walk into a facility and, perform a turnaround project, if you will, I mean, I have to look at labor, right? I have to. I mean, it's one of the reasons. I mean, it's my sample. It's a little bit lower. We're talking 40 some percent is my labor compensation ratio mean. In many facilities, it's upward of 60% of our cost structure, right? So if I'm asked to come in and do a turnaround, I have got to look at the labor pool, right? I've got to figure out, where I can slim and, do some of these administrative functions. Can we outsource that? Can we outsource our billing office and our revenue cycle management office? Can we outsource our supply chain? Do those need to be employees that work for us, or could they be a contract?
Or AI?
Yeah, and that's one of those things in the future.
Right.
We might be have AI doctors. Why do I need But I digress.
No, it's absolutely true. I mean, AI. We're going to do a whole segment on AI and how it's going to affect medicine in general, but also how this the delivery of care. But with the expiration of enhanced ACA subsidies, which is now, it's happening this year, do you see this coming to a head with hospitals? You're going to see more bankruptcies starting now?
It's hard to say what Congress is ultimately going to do. I think there's two questions there. Should the subsidies be extended?
What do the subsidies do? Why don't you unpack what do the subsidies actually do? I know in my view, they kind of mask a problem with just a bunch of money that's being thrown at it by taxpayers. But what do they actually do? Where does the money go?
To the insurance companies, right? So it goes from one taxpayer to the government to the insurance company. And this is it's something I do in class all the time with some of my students, and helping them to understand actuarial and experience rated insurance versus community rated insurance, one, and then to help them understand what the true cost of insurance is. So there's a site called healthsherpa.com. And if those that lived through the ACA launch, you probably remember how we had all kinds of trouble getting the website up and running.
Yeah, billions of dollars of waste, and then it didn't work.
Yeah, and it just was dysfunctional, at best. There was a group of Twitter coders at the time over a weekend, probably with a few cocktails, basically got a website up and running that was functional, useful. You could actually go on there without having to go through all of the firewalls and all the logins and screens with the government website. You could literally go on and start to shop for health insurance based on where you live or based on your zip code and a few demographic questions. So you can still go to it today. You can still do the exact same thing. So I walk my students through it. Minimal questions. And one of those, of course, is income. So if I put in that I make $250,000, I live in Comal County, Texas, I get a list of different insurance offerings, at the bronze, silver, gold levels, and of course it also shows your premium as well as your deductibles. And there's some usage, questions in there as well. And then you can go on and actually also, I just go back and edit it. So I make $50,000. Well, what used to be a $1,200 or $1,400 or $1,500 a month premium now is nearly zeroed out, right? So that's premium support, where the insurance company gets basically a supplementary payment from the government or from the U.S. taxpayer, those of us that are paying taxes, to supplement the insurance for those that need it or signing up for it through whatever exchange, whether that's the government exchange or if you're just buying it off of a website like Health Sherpa and signing up with Optum or whatever health insurer. So these premium subsidies effectively are doing that, right? They're taking the cost of insurance from what it really is in the open market down to something that many would, me too. I would love, if I'm having to pay for insurance, I would love to pay next to nothing versus $1,500 a month. So as these premium subsidies go away and they're no longer being offered by the government,
You're going to be exposed to that full premium.
Now we're talking the full cost of health insurance, right? Which of course,
Yeah.
you don't really think about it. I mean, I would complain about it too, but it's only really been artificially propped up.
So to your point, to your point before, it's just masking it. This last 15 years, it allowed the insurance companies to raise premiums kind of undercover, with support from the taxpayers.
Well, and I can't 100% blame the insurance companies though either, right?
I don't blame them. I don't blame them at all, because they're just doing what a publicly traded company would do. They're not doing anything different than any other company.
We have to recognize, up to this point, we were on actuarial-based, evidence-based, experience-based insurance, right? Based on your health history, based on known health conditions, your premium would be X. And we had years and years and years and years of experiential data to be able to draw from to determine that premium. Now, of course, what that did was lock out those that had a significant personal need, right? So we moved from actuarial-based or evidence-based determination of premiums to community-based determinants of premiums. So if we're all living in the same county, my insurance premium is very much predicated on how you look and how many health conditions you have, and how how you've addressed your health concerns, not necessarily just on mine. So if I go into that Health Sherpa site and I change my zip code from Comal County to Guadalupe County, the amount of my health insurance premium changes, right? Down. It actually goes down, because here in New Braunfels, Texas, we like pizza, bratwurst, and beer, right? So a lot of us have very wide front porches. And because of that, we pay more for our health insurance premium versus the more rural, side of the county, or Guadalupe County, where they're a little bit more fit. They have a younger population in and around the air bases, that is what it is.
That's startling. I did not fully appreciate that it was down to zip codes like that. More of when it's a community-based model.
You can do this experiment yourself. Go in looking around the Houston area and just change the zip code.
That's very enlightening. It's probably why mine's so high, because I live in the Woodlands, which has a very wealthy population who also like their scotch and eating fat steaks and stuff, and so they have an ability to pay for it, but they also have quite a heavy need in the medical side. So interesting.
So effectively, what we saw the insurance companies have to do. I mean, not that I always want to side with the insurance companies, but they had to effectively price in the risk, because they really had no idea of who was going to be in their risk pool, and then how much that risk pool was going to cost. Right now,
I think that they like, to your point, they wrote it. The AHIA had a very heavy hand in writing it, and they guessed the worst case scenario and didn't adjust. I mean, $22 billion in profits for United Healthcare. I think it was in 23 or 24, plus subsidies. That's without subsidies. That's before subsidies, is pretty egregious. And somehow they should have been able to adjust that year by year based on the reality of data collected, not on their guesses in 2010.
Yeah, make no mistake. I'm not in love with the insurance companies. I think they have greatly, in my humble opinion, and, I'll just speak for myself, I think they have greatly exploited the circumstances. And even though their medical loss ratio is actually going up, I think the premiums that they have been extracting from the U.S. population are, they're untenable. And now the question is where's the tipping point? At what point do we see a population that simply says, I can't afford this anymore? And employers too.
I think we're seeing that now. I'm seeing it. I can tell you, Lee may disagree with me, but in my practice, we're what, in March, and so I don't have much data. But I'm seeing. I did my first surgical day in my office, where 30% of the people were cash pay. because they had chosen to just forego any insurance and deal with, save the money themselves and deal with whatever came up. So luckily I do have a cash option for folks, but that's decidedly different than it's been in the last years. I have them, they come in every now and then, but I had a significant day in February where not the majority, but a significant number of the patients were paying out of pocket and didn't have insurance.
And then on top of it, you have insurance companies. I'm not going to mention the name of the one I'm specifically speaking about, but which you are providing a service in your office at a significantly decreased cost compared to what it would be in a surgery center or what it would be in a hospital. And they're going ahead at a certain point and saying, you know what, we're not going to let you do it in the office anymore.
Yeah, you can't do it there. That's one of the points that I wanted to make to you before, Brad, which was this set up to fail. I believe the subsidies were a little bit of a kickback for pushing towards larger facilities to aid in consolidation. The more money that you have flowing to a hospital, obviously the more money they'll be able to purchase private practices with and consolidate. And so when I see moves like that by private insurers that don't make fiscal sense to push towards high-priced care and then wait for subsidies to maybe neutralize some of that, what I see is, again, a system designed to drive consolidation and collapse. But again, I'm spitballing. Yeah. So I did want to ask you one more thing, Brad, before we kind of wrap up this portion of it anyway. So we understand that with the loss of the subsidies, with the pressures that have been developed inside Obamacare for the last 15 years, that hospitals are at a little bit of a watershed moment. What do you see as a possible reaction to the loss of subsidies in general across America? If you could just give me like a little bit of a hunch that you might have where we might go from here and what policies we might try to implement to mitigate that.
Other than the insurance company's earnings going down.
Right. Well, everyone knows no one will stand for that.
That'll never happen.
Right. But I mean, what do you see? Do you see any sort of action from Washington, either sort of an emergent action or definitive, that might help this? Aside from extending the subsidies, what could they do to mitigate the loss or the pressures on these rural hospitals?
What I think could happen versus what will happen, it probably are two separate things.
Always is.
I think probably the most significant thing, if the premium subsidies are no longer there, of course, I think we're going to see, a lot of popular press media, especially that's leftward leaning, that, and there's going to be a significant uproar, and of course there's going to be a lot of finger pointing, blaming, and that sort of thing. Honestly, and I hate to say it, and I don't mean, ill on anyone. And I know there's going to be a lot of people that are going to be put in pretty serious, situations, especially if you have a young family or whatever, or have, significant health needs and need that insurance. I think you're going to see a lot of folks that will simply not be able to afford, to maintain health insurance coverage, at least in its current form. So at what point, do we have a bipartisan agreement at the legislative level to come up with an alternative plan? I think there's a few ideas that are being floated around on the Republican side that are perhaps a high deductible health plan with health savings accounts, might be an option, that we might want to.
What do you think about Trump's suggestion that we give a lot of the subsidy money or all of it directly to the consumer, the patient?
It's an idea.
And then the undertone there is they may then be able to choose. So instead of the pressure from private care or private insurers is to push people towards hospitals, a person who is coming as a consumer to a doctor's office can shop around then and say, well, you're going to charge me X for this surgery. The place down the street can charge me less than that. I'm going to go there. What do you think that would do to help people afford health care?
And understanding, of course, that money only to be used for healthcare.
Right.
Yeah.
I think it's it's probably the most. Do I think it's actually going to happen? No, but do I think it'd be something that could push the healthcare system in a positive direction? Yes. And any time where we can reconnect the provider of any service with the cost of that service, I think is only going to work the magic that we have long known that happens in other markets, right? Anytime where we can say where I become and I have a finite set of resources that are in my account, and I have to shop around and be the best consumer and be able to stretch that dollar. Again, it's back to Adam Smith. We're back to each operating with our own personal economic best interest in mind. I think it can only it can't hurt. I mean, now what it will do from a hospital perspective is it's going to force hospitals then to be able to accurately price their offerings, right?
Yeah.
For Lee and I,
imagine that.
We've had our conversations. Ben and I and Lee and I had a conversation before you joined. One of the big problems we have at the hospital level is hospitals. Now I can't say all, but I would argue many, if not most, hospital leaders do not know the actual cost of the services that they provide. Okay. Now, someone could argue till the cows come home that I'm all wrong, and I would love to hear that conversation. I'd love to be part of that conversation. But if you don't understand the cost of what you're providing, it makes it very difficult to price it effectively, right? And
Again, I 100% agree with you, and I've had conversations with people who are in high positions in local health systems to that effect as well. Look, I really appreciate all of the stances that you take and all of the information you give it. As you've definitely kind of pulled the veil off of where we're at from a hospital finance perspective, and I really appreciate your views on that. The Affordable Care Act reshaped health care coverage in America, but it didn't eliminate the deeper economic pressures in the system. The question now is what happens next, and whether the next round of reforms will address those underlying incentives. And Brad, I just want to thank you for helping us understand the policy realities behind the headlines. And I'm really excited to talk in our next little go-round about where we go from here and what we might be able to do to help the situation. Thank you very much.
Thank you, gentlemen. Appreciate it.